Welcome to Doc Discussions with Dr. Jason Edwards, brought to you by St. Luke's, St. Louis.
Hello, this is Jason Edwards, and this is Doc Discussions. I'm here with one of my coworkers, Ashley McGuinness. Ashley, how you doing today?
I'm good. Thanks so much for having me.
Ashley, you're a dermatologist who specializes in Mohs surgery. Is that correct?
That's correct.
Yeah. And where are you from?
I'm originally from St. Charles, so I'm a St. Louis local.
Very good. And then where did you do your schooling at?
So I did my undergraduate studies at Rockhurst University in Kansas City, Missouri.
How about that? It's a Jesuit college, right?
Jesuit college. So I went through the Catholic school system here and stuck around with it for college, and then transitioned to SLU here in town for medical school.
Okay.
And then after that, I did my intern year and my 3 years of dermatology training at the University of Iowa in Iowa City.
Sure.
And then after dermatology, I did the Mohs surgery fellowship up at Mayo Clinic in Rochester.
Just up the road a little bit,
Yeah, just
right?
up the road. Kept graduating further and further north before I moved home.
Yeah. I remember my interview at Iowa, and to me, it seemed like a great town. Iowa City and Corvallis, I think, which is right next to it, I'm probably mispronouncing that.
No, that's okay. Iowa City is a great city, and it's not too far from St. Louis, but great college town feel, lots of fun things to do. You get the Division I sports kind of experience.
Yeah.
And Coralville is the neighboring suburb, and it's exploded. I mean, even since we started residency there, it grew a lot. They now have a minor league hockey team there that's pretty fun to attend to.
And, Iowa's kind of famous for their children's hospital overlooks the football stadium. And of course, football's huge in any Big Ten university, but especially Iowa.
Yep.
And the football players always wave at the kids in the Pediatric Cancer Center, which is a beautiful thing.
It's amazing. And it's really fun. I mean, being on both ends, one, if you're on a pediatrics rotation, being up there with the kiddos and seeing it, I mean, it makes everybody's day. And then if you're in the crowds getting to wave up there, I mean, it's very cool to see both the home team and the opposing team all getting into it too.
Yeah. What a special thing. And you're married to a physician, is that right?
I am, yes.
And so what's your husband do?
So he is a board certified anesthesiologist, but he actually did a fellowship in interventional pain.
How about that?
So he practices interventional pain over in Alton.
Very good. Very good. And so you've got a practice here in St. Louis, and we've shared a few mutual patients.
Yes.
Can you explain to people, like the layperson, what Mohs surgery is?
Yeah, that's a great question. So Mohs surgery is a specialized form of skin cancer removal, a surgical form of skin cancer removal. And the way we do Mohs surgery is it's all under local anesthesia, meaning the patient's not asleep for the procedure. We just numb it with injections. And we remove the skin cancer with a small rim of healthy skin. And while the patient waits, we check all of the edges, both on the outside and the deep edge, to see if everything's off the patient. If there's a little bit more, I have a map that I've created on both the patient and on the tissue that I've removed that tells me where we need to remove a little additional skin. And we repeat that process until everything's gone. And then we reconstruct the patient based on what the final defect is.
And so when you make the map, I remember in textbooks, they kind of quartered it where they make it into quarters. Is it more complicated than that, or is each section quartered?
It's a good question. So it depends on the size and the shape of the lesion itself. So sometimes you'll process it just in one single piece. Mm-hmm. I personally make more of our standard size pieces. I mark at 12 o'clock, kind of some hashes at 12 o'clock, 3 o'clock, 6 o'clock, and 9 o'clock. So it almost looks like a little clock face.
Yeah.
And we put inks in there. So it tells us, the blue ink may be at your 12 o'clock and your green ink is at your 6 o'clock. And if you see something between 12 and 3, you just take tissue between 12 and 3 and you can spare the rest of the healthy skin. Yeah.
So you excise kind of the same amount of tumor as you would with, which is all of it with a normal excision. But the beauty of Mohs is it leaves more natural tissue, more normal tissue. And so your surgical defect is less, right?
You got it.
And so you have a better cosmetic outcome.
You got it. Better cosmetic outcome. It's tissue sparing. And then the way we actually process the tissue, you're actually evaluating 100% of the margin margin as opposed to a standard excision. You look at 1 to 2% actually of the standard margin.
Yeah.
So it does give you a superior cure rate. You're talking more for your average run-of-the-mill skin cancer, 98, 99%, as opposed to about a 95 to 97% cure rate.
Yeah.
But huge benefit for cosmetically sensitive areas like the face, where you don't have much real estate to spare and you want all the healthy tissue you can keep.
For sure. Yeah. And when we're talking about skin cancers, specifically here, we're talking about basal cell carcinomas and squamous cell carcinomas, correct?
Those are our most common kind of bread and butter cases that we do a lot of. People are starting to use Mohs for melanoma in situ and thin melanomas, your early stage melanomas, especially on the head and neck.
Yeah.
We do Mohs for more common or for more uncommon skin cancers as well, but they're just few and far between as opposed to basal cells and squamous cells.
And the rationale for not doing it for kind of a standard melanoma or more advanced is you really want a very large rind of normal tissue between the blade and the tumor, because you don't want the margin to be as close with the melanoma because the recurrence rate's higher.
That's correct. And the other thing is that it just has been standard of care to have wide local excision for so long. So I know a lot of people are starting to do studies and kind of compare Mohs for melanoma to your standard of care, which is wide local excision.
Yeah.
The other thing that makes it difficult is if you need to do a sentinel lymph node biopsy for an aggressive melanoma, you can't necessarily time that very well with Mohs. It's hard to do when there's two surgical subspecialties that are both in the mix.
And another thing I remember from my textbooks, there was kind of a region of the face. And I think the rationale was that it was kind of like this embryological H or center point where cancers were thought to be more aggressive. Mm-hmm. Am I anywhere close on this? That's
correct. So we call them the high risk, medium risk, and low risk locations, but it is more central face. So kind of eyelids, temples, ears, nose, lips that are traditionally thought of as your high-risk areas.
Yeah.
Skin is thinner there from a cosmetic standpoint, a functional standpoint. You don't have much real estate. And because of the nature of the tissue there, skin cancers can behave more aggressively in those areas. So typically, if you have a basal cell or a squamous cell in those areas, it automatically qualifies for Mohs.
And then I also remember, like with the lips specifically, that cancers are more prevalent on the lower lip compared to the upper lip. Do you know why that is?
It may be. I don't know if it's because you get some shading from nose and that sort of thing.
Good mustache.
A good mustache on a man or a woman, I guess.
Yeah.
But, I think some of it is just anatomic location with it being a little more exposed to the sun.
Yeah.
I don't know with tobacco exposure, a lot of times with like chewing tobacco and things like that, a lot of times people have it stored in their lower lip. And we know tobacco use also increases your risk of squamous cells on the lip as well.
Yeah. Now, I'm going to get into the old online misinformation here. Okay. So recently I've seen some posts where people talk about this. It's actually the sunscreen that's causing the cancers and not the sun itself. What are your thoughts on that?
So I think it's been well proven that UV exposure, both chronic, a cumulative sun exposure, as well as intermittent intense sun exposure. So a sunburn here or there does increase your risk of developing skin cancer.
Yeah.
I know there's been a lot of concerns over, especially chemical sunscreens in recent years. What types of effects are these having? I don't necessarily think they're causing skin cancers. I don't think we necessarily know. Could they be harmful in high doses if they were in your bloodstream? Maybe. I don't think you're absorbing enough of it to probably reach those levels of harm in general, which is why they've been approved for use. But I always tell people, if you're very concerned about it, some good alternatives would be like a zinc oxide, titanium dioxide, more of those physical sunscreens. Because the way they work is they actually sit on top of the skin. They're not actually absorbed into the skin, and they still provide a protective barrier from UV. Or just using sun protective clothing. They make a lot of UPF clothing that actually has that sun protection built in now. So if you're concerned about it, there are alternatives to still protect you from the sun. And protect you from that UV-induced damage.
Yeah, I mean, and when it comes to just like misinformation and stuff like this in general, I mean, it's okay to be skeptical. I think you don't want to be naive. And so it's okay to have some skepticism. But, from all the evidence out there, it looks like sunscreen in general is very safe. And then there's some kind of, like you said, higher end ones that, maybe technically safer.
Right.
But yeah, and then the sun shirts, I mean, those work. You can get in the water and it's not like the old Cotton Hanes shirt.
Yeah.
I mean, they're breathable and the technology with the clothing's good.
Yeah.
And so that's always a strong move.
Yeah. And I think it's nice too for people who say they don't like the feel of sunscreen or just forget to reapply.
Yeah.
If you've got a sun shirt on, you've got that SPF of 50 essentially built in for as long as you've got it on, which is very nice.
Yeah.
If you're going to plan on spending the whole day outside.
I totally agree. And, you're in the water, comes off, or I don't know how well it stays. Even if it's the waterproof, you don't know if it's going to stay or not.
Right.
But,
exactly.
there does appear to be a trend with increasing not only rates of squamous cell carcinoma and basal cell carcinoma, but also melanoma, since 2000, at least through 2020. And what I'm looking at here, it says about 1.8% annually, which seems like a lot. Have you guys noticed that? And what do you think's behind it?
That's a good question. And I think there's a lot of factors that probably play into us seeing more and more of it. One is, I think, patient education. People are more and more aware and are taking a look at their own skin, which is awesome because, you're your own best advocate. So if you're the one that sees your body every day. So if you're noticing it and bringing it to somebody's attention, I think that is something that has driven numbers up.
So just better detection.
Better detection and, better detection by patients, better detection by dermatologists, as we know more and more patients are seeing dermatologists. I think our aging population in general increases those numbers just because, it's cumulative sun exposure risk. I think tanning bed use, especially in, we think about rates of tanning bed use 80s, 90s, early 2000s. I think we're seeing a lot of repercussions of tanning bed use as well.
I grew up in a small town. In small towns, everything's tanning. It's like there's a pizza shop and tanning. It's like a combo. There's the gas station and tanning. It just goes hand in hand.
Yep. And it's shocking that you still see them. We know how bad they are, and there's still a few lingering, which is concerning.
Yeah. So when you talk about ultraviolet light, which is, what we consider the kind that damages the skin, that causes DNA changes, which precipitates cancer. There's UVA and UVB light. Is one of them worse than the other?
Doc Discussions with Dr. Jason Edwards. Brought to you by St. Luke's, St. Louis.
It's typically thought that, UVB typically causes burning rays. It doesn't penetrate as deep into your skin as the UVA. UVA penetrates a little bit deeper. So traditionally people think UVA is what causes aging and more of the skin cancer, that those cellular changes. Yeah. But it's really a combination of both. So that's why they always say when you look for a sunscreen, look for something that says broad spectrum because you want to cover yourself for both.
Okay.
And they both penetrate even car windows. So I always tell people you should at least be putting something on in the morning. At least do your face, a daily moisturizer with a sunscreen. Even if you're not going to be out and about, you are still getting some of that exposure.
Yeah, I started using this brand called Proven, and you probably,
I haven't heard of it.
There's all these products, right? But it was, of course, developed by dermatologists. That should be your next venture, right?
Right. Developed by dermatologists and a radiation oncologist.
But it, developed by dermatologists, and everything's, supposed to be like heavily scientifically studied, and they take, it's personalized, right? I mean, people don't know. You can get personalized vitamins. You can, you can send off a stool sample and get personalized vitamins, all kind of personalized stuff. But it's, this is not as intricate. They just get your demographics, where you live, and then send you, face cream or what. But it has, I can tell there's sunscreen in it. Yeah. And I don't get out that much. But we all want to stay looking young. Yeah. And part of it's certainly sun damage. What other things that, cause the wrinkles, or age the skin?
Yeah. So I think UV exposure is a big thing. A lot of times people also notice that just dryness of the skin. You know, when you're dry, you tend to notice some of those fine lines and wrinkles more than you would if your skin is moisturized.
Yeah.
So keeping nice moisturized skin also makes you look a little more youthful. And then also just dynamic movement. You know, we move all of our muscles. Every time we move our muscles of our face, they make wrinkles. The more you move those muscles, you get wrinkles, which is why people do Botox to paralyze some of those muscles.
Okay. Yeah. And then of course, you know, there's, one thing I notice with patients, if I see somebody who looks, you know, significantly younger than their age, you know, with regard to their skin, I think usually I'll ask them, do you drink a lot of water? Because people will just drink a lot of water, you know, or you know, that's a part of their, you know, their regimen is to, drink plenty of water. And I think that alone, you know, helps reduce the wrinkles.
Oh, yeah. Hydration status is huge. Definitely. And then things like, you know, smoking and alcohol use, we know contribute to accelerated aging as well. So kind of just having that healthy lifestyle overall, you know, water consumption, healthy diet, avoiding heavy amounts of alcohol or tobacco use in general.
Yeah.
All go a long way, both on the inside and on the outside.
For sure. Yeah. You know, I think of Lenny Kravitz, who's the singer, who's a raw vegan. And I mean, that guy looks great.
He does look great.
And I mean, sometimes it could be just genetics too.
Right.
But I mean, certainly eating kind of a low nitrate diet, you know, like you said, helps inside and outside. And if you have great blood flow, you know, to your heart and your kidneys, you probably have great blood flow to your skin.
Exactly.
You know, AI, artificial intelligence is kind of all the new rave. Have they integrated any of that technology into Mohs or dermatology?
They are starting to do some studies. Actually, when I was at Mayo Clinic for fellowship, they were starting to utilize a full body camera for high risk patients and kind of studying that for mole mapping, essentially to look for changes. And they were going to use AI technology then. At each visit, they'd have the patient photographed and then have an AI algorithm look for subtle changes in moles that then would be followed up with a dermatologist, you know, dermatoscopic, you know, better evaluation. So that's one thing I've seen. I've seen a lot of apps now kind of advertise that are take a photo of your spot and upload it and kind of get a diagnosis. So I think they're trying to refine some of those, and some of that may be very helpful, especially when triaging patients, you know, and you're doing almost a telederm. Does this need to be seen next week, or can we maybe see this next month? So I think that's nice. And people are starting to actually implement it in Mohs in terms of seeing how AI compares to a physician in terms of, can it identify a basal cell or not, and what's that agreement like with the Mohs surgeon?
Okay, so do like a kappa analysis between the two. Yeah, I think the taking the pictures, I mean, even with people with their phones, is one of the things that you just never had before. Because, you know, when you see a patient and make a note in a, you know, write about something you know, it's hard to really tell how it changes over time. Usually as a doctor, you just see them in one point in time and kind of make a judgment over that. And so that's really cool to have, you know, something that kind of tracks it. And so you kind of have this dynamic picture of what's going on with the lesion over time.
Yeah. It's very, very interesting. And they were even talking about adding dermoscopy, so like magnifying the lesion and looking at pigment patterns. And even from that even magnified view, looking at these very subtle changes in moles, which is very cool because it's something, like you said, I mean, we're seeing them as snapshot in time. So if you have these photographs and then have something that can pick up very subtle changes in color that maybe our eyes can't even pick up. I mean, it's just adding another tool to your armamentarium. Obviously, you always need the clinical aspect behind some of that AI stuff, but I think it's just going to be another tool for us to use.
Yeah, I think that's it's kind of like a co-pilot, right? It's just something to help you be better. And then, okay, so you got squamous cell carcinoma, we got basal cell carcinoma, and these are the common cancers. And most of the time, you know, they don't spread to the lymph nodes and they don't metastasize. When they do, it's wild. I mean, you know, it's very rare, but when they do spread to other parts of the body, I mean, they can be really aggressive.
Yes.
But melanoma is like the really scary cancer because that doesn't have to be very big before it gets into the bloodstream and can spread anywhere and everywhere, and it does. And the metastasis can bleed, and you know that's a big deal. What are the, you know, when somebody's looking at a lesion, what are the main like criteria that would be like suggestive of a melanoma?
That's a good question. So for the most common subtype of melanoma, it's called a superficial spreading melanoma. And because it's the most common, people have come up with all sorts of things to help people identify, worrisome signs on themselves. So I think the most common and most helpful one is the ABCDEs of melanoma. So when you look at a mole, something that's asymmetric, something that's borders are irregular, if a lesion's got multiple colors, so if you're looking at a spot and it's uniformly brown, that's a reassuring sign. But if you see brown with black and blue, that might raise your suspicion.
Yeah.
For D, they usually say bigger than the diameter of a pencil eraser. And then the big thing for me is the E is the evolution. So if you had a mole that it looked one way for 10 years and 3 months ago it started to look a little bit different, that should really raise your suspicion.
Yeah.
And all of those are just kind of guidelines. You can make normal spots that break some of those rules, but it's helpful for somebody who's seeing their skin at home or having a loved one take a peek at their skin to say what of these might be worth calling a doc about.
And, I have a rule with things that may be melanoma, and it goes with your E. You're saying the E is really important for you. If a patient's concerned, then usually I'm concerned.
Yes.
Or I'm saying, don't sleep on that. Trust your instinct. Because, we all have spots all over us.
Yeah.
There's a reason you're concerned, and it's probably that it's evolving and it's changing a little bit quicker. And so I always tell patients, if you're concerned, just go ahead and get in and see somebody.
It's better safe than sorry.
You bet.
Yeah.
Now, Merkel cell carcinoma, they always say it's similar to melanoma. It's caused by polyomavirus and stuff like that. It's a little bit different. But is that mostly on the skin too?
It is. So, and I think Merkel cell in general tends to overall behave more aggressively. When you catch it, typically people are needing a sentinel lymph node biopsy, sampling their lymph nodes no matter what, in addition to local control of the tumor. Whereas melanoma, if you catch it early enough, it's surgical removal and you're kind of done with it.
Yeah.
But it tends to be on the skin as well.
And, the very first episode we ever did, I talked about Jimmy Buffett, who I'm a big fan of, and he had Merkel cell carcinoma and ultimately died from it. And so of course, Jimmy's near and dear to my heart. But the one, there's several cancers that are highly immunogenic cancers, meaning the immune system plays a big role in modulating the cancer and kind of keeping it in check or not. And so if you're immune compromised, you'd have worse results. And if you had a good immune system, it may keep it from spreading. But specifically melanoma and Merkel cell carcinoma are highly immunogenic cancers. And so they've got these new immune therapies that they use, sometimes in lieu of chemotherapies, but it's a systemic therapy. And I've seen some just dramatic responses, especially with Merkel cell carcinomas.
Yeah.
Previously you thought we can give them something, but it's, some chemotherapy, but they're not going to do well.
Yes.
And then I've seen patients where it just melts away. It's very remarkable.
Yeah. The immunotherapy has been a total game changer. For metastatic squamous cell, for melanoma, for Merkel cell, because traditional chemotherapy, one, from a side effect profile, has historically been really tough on patients. And two, outcomes for a lot of these skin cancers were not as good as for other types of cancer with traditional chemotherapy. And with time, they've just expanded the armamentarium, which is awesome because it gives us more backup options and just more options for patients if they don't tolerate things.
Yeah. Now, so you're a Mohs surgeon. Are you doing strictly Mohs surgery or do you do some regular derm with Mohs?
Right now, I'm only doing Mohs surgery.
Good. That's a good sign.
I miss general dermatology a little bit, but unfortunately / fortunately, the skin cancer treatment does keep me busy.
Good.
But like you said before, so many of ours are curable with very, very high cure rates. So it's a very rewarding type of procedure.
Yeah, for sure. And kind of going back to your training, dermatology's a tough specialty to get into. It was always the top of the top, that got into that. And then I'm sure out of dermatologist, getting into the Mohs fellowship is probably the same thing. Now I know you're not going to break your arm patting yourself on the back, so I will. But that's really, it's remarkable, and it's hard to get into those things and to be able to do that at the University of Iowa and then Mayo Clinic is, really remarkable. And to be honest, we're really lucky to have somebody like you in our community. And I'm glad that you're doing mostly Mohs surgeries because that's your specialty. And I'm glad you're popular enough that you're getting, enough patients to stay busy with just that. If you're a patient out there looking for a doctor, a busy doctor is typically a good doctor because other doctors are referring to them. I've been told never to do this, but I noticed you might be a little bit pregnant. What's going on there?
My husband and I are expecting identical twin girls come here June of this year, so not too far from now.
Well, God bless you. What are your thoughts on that? I mean, that seems like it's going to be a lot.
Yeah, so we're going from 0 to 2, which is awesome, amazing. We're very excited, but also terrifying at the same time. But, we're going to take it one day at a time, and they're already very loved by everybody in their lives, so we're very excited.
Yeah, I mean, you and your husband seem like you're very functional human beings, and it certainly helps to have some family nearby. And so you're going to have a little bit of support from mom and dad?
Absolutely. And we knew we always wanted to move home. We wanted to care for people in our community, but it's just an extra bonus now with 2 on the way that our parents are at most 10 to 15 minutes away from us.
So your husband's parents are here as well?
Yeah.
Oh, thank goodness.
It's going to be so awesome.
Yeah.
So he grew up in O'Fallon. I grew up in St. Charles, and
perfect.
We've got family all around.
Yeah, it's in many ways the most difficult thing you'll ever do, but also the most rewarding and challenging. But I think I think it'll be a true blessing, and you're probably bringing 2 smart kids into this world.
I hope so. We've had challenges in a lot of other areas of life, but this will be a totally new challenge, and I think we're up for it.
Yeah, and I mean, challenges are good for us. It's Sisyphus pushing the boulder up the mountain. You need that boulder. You don't want to just skip through life and not continue to grow as a person. And I think one of the things that makes people universally happy is to see progress in their own life. And then the beauty of having a child is you can once you've kind of ran your course, you get to see the progress through your own child's life. And so, in a sense, it's kind of redoing the hero's journey if you're a Joseph Campbell fan. But,
absolutely. Yeah, I think it'll be very rewarding and very exciting to see them grow and kind of do their own thing and develop their own personalities. And so it'll be very, very fun.
Yeah, I'm happy for you.
Thank you.
So I mentioned Joseph Campbell. Are there any good books that you like?
So I am a historical fiction lover. That's like what I tend to gravitate towards. So I actually just finished The Women. It's about the nurses in the Vietnam War, and it's a historical fiction book, but it's kind of about the unsung, people who weren't really acknowledged, but did a lot of care and hard work during the Vietnam War. But I love historical fiction books, especially ones that have strong heroine stories.
Yeah.
So the Alice Network is another great one about like an underground female-driven spy network during the Great War. And I just love those books because you learn a little bit, but they're still enjoyable from a fictional standpoint.
I agree. I mean, stories, just hearing facts don't really stick.
Right.
You need to be able to tell a story.
Yes.
So in that book, The Women, does it take place stateside or in Vietnam or in both?
Mostly in Vietnam.
Okay.
Yeah. So it starts the first chapter or 2, they're back stateside, but then she is deployed and working in Army hospitals in Vietnam. And it's very eye-opening because, a lot of it is based on things people actually experienced over there. And, the authors always do so much research to make it as historically accurate as they can. So it makes you appreciate people who put their lives on the line and take care of people who put their lives on the line for us on a daily basis.
Yeah. Yeah. Actually, it makes me think of my father. He was a corpsman, which is kind of like a nurse at Balboa Hospital during Vietnam. So he, when patients, he wasn't in Vietnam, but when patients came back or were flown over, he saw a lot of patients. And the military medical system, it's a little bit different than the general medical system. I mean, you have nurses do a lot more, in the field of battle for sure, or the theater of war. than, they do stateside. Not that they don't do a lot stateside, but I mean, they're allowed to do a lot more.
It's all hands on deck, especially, in the book they talked about the mass casualties, and it really is, you need everybody just to pick up whatever you can do.
Yeah.
So I think it was a great story about like teamwork and, emotional strength, physical strength, and just being there for each other. And that's what's important.
Yeah, for sure. I'll end on this. Actually, I did a short stint at Mayo Clinic, and they had a mass casualty event when I was there.
Oh my gosh!
Which is Rochester's a small city.
It is very small.
Beautiful hospital, huge hospitals, 100 and something OR beds.
Yeah,
it's
huge.
But it was this huge car wreck that happened. I don't think it was like foggy or something like that.
Oh my gosh!
And they were asking other doctors to come to the ER because it's just the last place you'd expect a mass casualty event. But that would have been like maybe 2010 or something like that. Oh my gosh,
I can't imagine.
Yeah, it was pretty crazy. I obviously didn't go. Anyway.
What a wild experience.
You always got to be ready.
Oh my gosh,
and sometimes things like that happen and you just got to jump in and help.
You do. It's like when you're on an airplane.
Yeah. Yeah. I'm always with my wife who's no OB-GYN, so I'm always safe on that one.
Same with myself and my husband. I'm like, if they call over, I'm like, you're the anesthesiologist. If you need me, then call for me.
Yeah. I'll be your backup. I'll be right there.
Backup, you're primary.
Ashley, how do people get a hold of you if they're interested in seeing you as a patient?
So typically, if you are interested in seeing me as a patient, you will need a referral from your general dermatologist if you have a biopsy-proven skin cancer that needs treatment. You can either call our office or make an appointment on schweigerderm.com.
And how do you spell that?
SCHWEIGERDERM.com. And I am currently at the office in Chesterfield, so Schweiger Dermatology in Chesterfield.
And so they can reach you at 314-878-3839.
That's correct.
Well, I want to thank you for the good care that you've given our mutual patients, and I want to thank you for coming on today, and I really appreciate you.
Thank you so much for having me, and of course for sharing patients and taking good care of our mutual patients. It's always a pleasure to share patients and discuss cases with you.
You bet. Thanks so much, Ashley.
Thank you.
Join us next time for Doc Discussions with Dr. Jason Edwards. It's medicine for your body, mind, and spirit.